Greg, thank you so much, and thank you everyone for joining us today for our second installment of the evolving relationship between OHDSI and clinical registries. And so we did one last year, and it's amazing how much has changed within a one-year time frame. I have really brought together a great group of leaders in the field of how we're working with clinical registries today, with Lee Evans, Dr. Dwayne Willett from UT Southwestern, and Jeff Weaver from Emory University. And so I'm hoping to get your help in this call. I would like to get you to use the chat as much as you can, and I need your help. I think it's really interesting looking at clinical registries. I find that sometimes it's hard to describe what a clinical registry is. I think at the simplest form, we describe it as a group of patients or a database that has a common data collection strategy around it, where it's a specific group of patients, such as with a disease or a condition, who are receiving a treatment or a medication. And so I break it down into two pieces. I think at the heart of things really is a cohort definition. And I like that because in OHDSI land, that is computational. It defines inclusion criteria and exclusion criteria, and it converts, when you apply it correctly, it gives you a list of patient IDs. But in addition to that, a clinical registry also has a data specification sheet, which means what data elements are they interested to collect around those patients. And I think what's really important about this is a clinical registry is really perfect for a health system to have a goal for converting their data to OMOP. And so it's, with OMOP, it's hard to figure out what your end goal is for your data. You obviously want to collect all your medications, your labs, your procedures, your conditions, and you don't want to go down the rabbit hole. And so it's always difficult finding that sweet spot of where you feel done is, and it's always an ongoing role to enrich your data. But a clinical registry is a perfect place to start for a health system because they have a data what data elements are important to them that they're trying to ask questions about. So I'm a big fan of clinical registries and their ability to help health systems really start their journey with OHDSI. And so with that, I also I wanted to know, how many clinical registries are there? Does anyone here know how many clinical registries there are out there? There can be disease registries that we mentioned. There's surveillance registries. There are outcomes and pharmacovigilance registries. Anyone have a guess on how many registries there are? And the funny thing is, I don't think anyone has any guesses that are on the mark, because the truth is nobody knows. There can be sites that are registries that are using the OHDSI data model, and we may never know. But there are expected to be thousands of clinical registries in the world. There is not a central registry of clinical registries. The WHO has a list of a couple hundred registries, but I think this is really interesting in that there are likely thousands of clinical registries in the world where organizations, specialty societies, trying to understand the outcomes for patients, are trying to collect data, but there's not really a central way of doing that. So the first question is I still feel like, so please, I would love to get a list of how many of where you think they are. What we do know is that clinical registries are under a lot of strain, and they're not very cost effective, in that right now they are mostly still manually operated with REDCap and or electronic data capture tools, where they're taking valuable time away from providers, from nurses, from clinicians, which has been demonstrated to be about a half an FTE for every few hundred patients just to collect that data, and it can be multiple hours. And so this is, I think, a real challenge to most registries to collect data, and also they have problems with keeping that data up to date and creating a latency in that data. So I think that more and more clinical registries are turning to EHR automation to help them collect a lot more data about their patients and then help them fill out their registry. And I think that's what's exciting. We've shown there are great papers now that OMOP is an excellent data model to facilitate clinical registries. It can provide more efficient collaboration between researchers and help you establish your federated data network. And I think that for me, today's discussion is, how can a clinical registry really take advantage of the OHDSI community? how can this benefit the OHDSI community, how this can benefit the clinical registry, and how this can really benefit the health systems that are contributing data for those clinical registries. I see this as really three major forces that can come together to really improve the efficiency as well as the quality of the data that we collect to help us conduct better research on our patients. So how many, so one is, of course, clinical registries collect lots of data around patients, and some of it is more feasible than others for using with OHDSI. For example, we know that if the data already is in one of our 150 clinical terminologies that are mapped into OMOP, then your life is going to be much better. If the data is mapped, like I think we've gotten very proficient at medications and labs, procedures, conditions, devices. A lot of this can come out of the box with your mappings from your EHR, which are usually coming from coded data sources into the OMOP data model. But then things can get more complicated. Obviously, we know there's a lot of manual data sitting in EHRs, in flow sheets or smart data elements. And so we know that a lot of data still needs custom, it's in a variable somewhere in your EHR, but that variable doesn't have enough definition around it to know that it's tied to a certain clinical terminology, to a LOINC code. And so there needs to be some custom mapping of data elements within your EHR into the standard terminologies. And this is fairly straightforward. I think we've gotten pretty good at this as a field. And then also we know that some data might not even exist in our clinical terminologies. We have something, I think, on the order of 9 million concepts in our OMOP vocabulary. However, whenever you apply this to a specialty and you start trying to collect all the data that you feel matters for your patients, you're going to find about a 50% overlap or content coverage analysis between data elements that are valuable and data elements that don't even have a terminology associated with them. The good news is OHDSI is very good at being flexible and allowing you to add custom concepts. So it's a very extensible model in being able to add in custom concepts. And this is where clinical registries can benefit in that within your group, you can always use the same concept IDs, even if they are custom. So you can allow yourself to do research within your community, even while those terminologies go through the standards development process to be added to SNOMED or to your favorite terminology. And then there are things that take more effort, like imaging and bringing in features from that, which is a great deal of area I put my work into. I think most importantly, people are looking towards NLP because there's a lot of things that are interpreting the clinical notes that we need to have done that are still significant effort. And this is really where we need to help move the field. And today we're going to be talking about ways that we can try to help develop and deploy technology within health systems in a supportable way that can help them begin doing natural language processing. Okay, so this is all exciting. You see the advantages of using OHDSI with registries. How many registries now? So now I want you to add into your chat, how many registries, clinical registries are using the OMOP data model? And Patrick, I'm hoping you can tell me, I can't see the response. Let me know how many, what are we seeing for responses?
No, people are being shy to guess. Got a guess of 22
out of thousands
10?
Of clinical registries. Well, that's
175, 50.
75. So if you look at the annual report, and so I looked at the annual report with Claire, and most of it, and we looked for. We usually look for the word registry. That was a good clue. But also the ones that we know about, we found about 18 that we clearly were identified as clinical registries. But you're right, that's actually a very small fraction of them. And so one of the things I think is a big opportunity today to help the clinical registries that you work with take advantage of OHDSI. And I encourage you to join Tina and our OHDSI Clinical Registries Working Group to help our clinical registry provide a roadmap for clinical registries to help them transform and take advantage of OHDSI. So I still think that we're in early stages. I do feel that EHR automation is a disruptor And a disruptor is a specific term that we use in informatics to the field. And we use, I don't know if anyone's familiar with the diffusion of innovation model. We live and breathe this in informatics. It's about how technology is adopted by different communities. And it dates back to 1940s Iowa farmers' adoption of hybrid seeds, but basically identifies that there's really 5 different types of personalities and social economic categories of adopters. And it could be for any technology from washing machines to EHR automation within health systems for clinical registries. There's usually innovators who are really eager to be the first on the scene. Then we see early adopters who have some want to though they see the value from the innovators, but they're really interested in getting good value out of it. Once the early adopters really begin to use it, we then start seeing early majority of registries beginning to take off and getting value for it. And then we have registries that are a little bit waiting for things to be well ironed out and proved and make sure that there's a clear case around it. And then, of course, there's the traditionalists who are waiting until that don't like change. And these folks are now ready to move from VCRs over into DVDs. And so generally what we're seeing is I would say EHR automation really took off in the 2010s as the adoption of EHRs themselves took off. Now that we can collect this data digitally, I do feel like what we're seeing now is we're entering in the early adoption phase of using for clinical registries where we can use automation plus standardization. It really, if you are doing EHR automation without your own data model, you're really going to have a very difficult time making it cost effective, and you're making for fragile interfaces that are hard to maintain. And so by taking advantage of the standard OMOP data model, we really feel like this is going to be the bridge to the early majority of clinical registries. And just in case you're interested, what are some of the factors that really are going to be critical to the next steps of adoption of clinical registries for OMOP and EHR automation? And they are, historically, they are things like having reference implementations to build off of, clear adoption of standards that become path dependent, clear de-risking of the cost of doing it, reducing the technical barriers, having availability of people that can actually perform the tasks is a key step, and then having clear financial incentives. That's the last one usually is really what the traditionalists will need. So these are the things that I'm looking for as we start watching the clinical registry revolution as they start adopting the OMOP data model. And so I would love to hear if there's any registry that you're aware of that uses the OMOP data model. Please add it into the chat now. Claire, Tina, and I will try to make sure that we keep track of them all. But I really feel it's really interesting just getting a sense of where the market is moving and where we are today, because I feel we are very close to having a tipping point where we're going to see a large adoption of clinical registries as EHR systems and health systems like mine say enough is enough. I can't support all these different data transformations. I don't have the data analyst team to help map my data to yet another data model. I need there to be one model that I can then use to feed all these different clinical registries. And that's really the potential and value that we see in OHDSI and OMOP. So if you know of any registries, please let us know, and then we'll try to keep a log of them. Today, I'm going to be talking about a registry and the work done with the registry. And this registry started like any other registry. This was a great initiative that was launched by the NIH and the FDA. They invested $9 million to help identify repurposed drug candidates to treat infectious diseases. It started with an online case review form where they had over 300 sites in 28 countries submitting case review forms about potential repurposing of drug candidates. And this was basically a manual method. As you see here, I think one of the key metrics is it was taking 4 hours per patient for the clinical staff to be able to enter this data in, these hundreds of variables. And that is where most clinical registries are today. So CureID invested in EHR automation as the COVID pandemic began. They repurposed this registry to help really drive towards COVID. And they, I feel like what they've done is they've done what I'll consider the next generation of clinical registry for how can they really build out a clinical registry and really take advantage of data standardization, but also take advantage of the OHDSI community. And the ways that they did that, and I think this is really a role model for registries for the future, was one is we, instead of building another community elsewhere, they built synergy with OMOP and the OHDSI community. We created a Teams group under the Health Systems Interest Group. We created a GitHub repo under the OHDSI organization. And so I feel like this really helped us be part of the conversations and recognizing that health systems have many registries that they're trying to support, not just the CureID. This helped them build some synergy around that. They also built or focusing not just on sites that had data ready to go, but they really were helping focus on how do we build capacity at health systems to help lower the cost of ETLing their data and managing an OMOP data set. I think this is so important, especially in the United States, where the majority of care is being delivered in community health centers, yet the majority of health systems that are on OMOP are academic medical centers. And so I do feel like this is really a key mission for us, is to help lower that cost to be able to ETL data from different vendors into the OMOP data model and make it easier for them to refresh it and manage it and get value within their health systems. So this is something that I feel is really a great part of a next generation clinical registry. They also, I think another important thing was they encouraged the use of OHDSI software within the health systems. This is still actually fairly infrequent. Most health systems that we engaged with were not able to just install the software. We're just given an SQL environment, and we had to do all the transformations by hand and all the data quality checks by hand. And now note, those of us within the community realize how powerful Atlas is for helping you navigate your data. The data quality dashboard is for helping you perform data quality testing. Perseus has powerful tools like Usagi for helping you map uncoded terminology, and Hades has incredible R packages for helping you analyze this data and perform analysis. And so one of our missions within CureID was trying to figure out ways that we can get software and the OHDSI software into health systems in a way that they could use it to help them with their data journey within OHDSI. And lastly, they also, as part of that, they were willing to invest in the open source development for Perseus, for Broadsea, to help us lower the cost of ETL sites. So these are behaviors of what I consider are fantastic behaviors that I'd like to see other clinical registries follow. And I really feel like this is a way of not just benefiting that clinical registry and maximizing the benefit to them, but also benefiting our whole community with that. So just so you know, what was the custom data in CureID? Most of the custom data was around respiratory management, flow sheet data around trying to find oxygen devices that were being used, like the nasal cannula and the ventilators. And I know that we've talked a lot about COVID in the past 3 years. I won't go deep into it, but basically there were about 20 concepts. 10 of those concepts were in the OMOP data model. 10 of them had to be built as custom concepts. But this was a combination of looking at flow sheets and building out a slight custom extension of the OMOP vocabulary as certain other concepts go through SNOMED. So this was, I consider, a high yield, where the majority of data they're looking for were the medications being used, the procedures being used, the diagnosis codes, and of course all of the laboratory measurements that were being acquired. And so I think a lot of clinical registries fall into this bucket where 80% of what they're looking for are the basic facts that define the context of the patient and what's going on with them. And then there's going to be some key parts of it that are not. The American Society of Hematology has a great OMOP registry that's focusing on sickle cell patients, and they basically it's almost all vanilla OMOP, and then there's a list of genotype variations for laboratory testing that they have added. And so I think it's really useful to look at how much of a registry is already using the OMOP data model. wanted to mention the other benefit of doing this clinical registry with the OHDSI community is we were able to create, have a data core within Johns Hopkins. We have some great data people, and we have some great clinicians that can help map concepts into the OMOP data model. But there's a lot of things that we don't have. It does take a village. I'm pretty good with Epic. I'm not very good with Cerner. So we were able to phone our friends through the OHDSI network, and Janos and the Stony Brook team helped any sites who had Cerner on their OMOP journey. We were able to work with Roger, who's developed incredible ETL scripts from Epic on how to transform their data so that sites weren't starting from zero, but they were starting with base scripts and they just had to modify the scripts from the next generation scripts that Roger has built on the Epic user web. We were able to leverage Katie in helping us with doing data quality testing with sites, and we were even able to bring in Lee Evans to help us deploy Broadsea and Nate Buskins for helping us with ETL. The one person I did want to really recognize the most in this team was Danielle Boyce. She really was the face of this project, working with our sites, and really became, I don't know, the site whisperer of trying to help sites figure out what their challenge was to help them move them along. A lot of the challenges are finding organizational support or understanding the technical requirements or helping them install the software. Every health system is on their journey. They all have there's a lot of limited constraints. It's very hard to get data analysts within health systems with the right access to the SQL environments, with the access to all this clinical data to help them on their OMOP journey. And Danielle really became front and center to help moving our sites along with our project. Okay, so the other big thing that we really were trying to promote with the sites is that OMOP is not just another registry. The CureID is not just another registry. OMOP is a place that you can spawn lots of registries, both internally and externally. So we call it at Hopkins our OMOP Prime, and yes, it's a reference to the transformers, where basically we can create sub-registries just through a cohort definition. So we actually can use JSON and CIRCE and create a registry directly from a base OMOP instance, and so we can make many registries from one OMOP instance. And this really saves us enormous amounts of effort in managing our ETL. And in addition to that, we actually have lots of internal registries at Hopkins where we spin off many different things, where we have different instances of Atlas, which can map and tie authorization of users to different data sources and allow them to have access to registry data. And so we were sharing these techniques with the other health systems as a way of saying, this is not trying to help you just do yet another registry, but actually help you solve your whole registry management problems. And so, and just in that process, I think this was actually a really important point that a lot of the sites really see as a guide forward in the process. So we started working with different health systems. And we found that they fell into three camps. Some camps that were just starting their OMOP journey. A lot of systems already had a base in their organization. They had done an project. They had an OMOP version. It might be 5.2. But they had done a project and they had done some of the ETL, but it might not have been refreshed, or it was not being managed at the enterprise level. And then there are sites that are what I consider enterprise ready OMOP. And these folks really had a well-managed team. They had understood, they really were ready to go. They were teaching us things. And these are other groups that I feel could be their own data cores that really understood how to deliver the data back to their organization. I wanted to share with you, we ended up helping about 36 health systems on their OMOP journey. And I wanted to share with you what were the common issues that the sites had in this journey. And so, oops, I'm sorry about that. So the steps that we typically guided them through was, of course, helping them introduce them to the OMOP and connecting them with the OHDSI community, with Eden, the book of OHDSI, but also giving them some orientation. A lot of us trying to help them connecting their clinical and data teams together, helping them understand how to go through the IRB, understanding how to get into an enterprise organization alignment with how they use data. And then we would that was mostly organizational support. And then we would provide them technical guidance on how to really quickly go through the ETL scripts and give them feedback on quality checks that they could do fairly quickly as they start building out their base OMOP instance. And so I think the biggest timeline, of course, was helping them get external support, organizational support within their groups to be able to assign a data analyst to be able to get approval to do this. And then we spent a lot of time with sites helping them with their data quality, helping them increase their capacity for understanding how to audit and trace their data. And then, of course, we did work with them on OMOP enrichment for these flow sheets. And so as you see, these are just some of the sites that started without having any OMOP instance within their organization. And we're just happy to move them along in their journey to help them get enterprise approval that they're ready, that they want to do this. Our goal is not just to get them ready to submit to our clinical registry, but we really want to get them ready to participate in network studies. We want to help them to join our data partner network and to be able to be an active participant in creating evidence throughout our whole organization. Okay, so here are the top issues that we had from sites. I don't know if you want to take any guesses. Feel free to add them in the chat. And if you do, Patrick, you can let me know. What do you think the top issues the sites had? Do you think the top site issues were that they didn't have a database analyst, or that that it was a technical challenge? I can tell you the biggest issue sites had was the clinical investigator had no idea how to find their OMOP team. So of course, any registry is going to go work through their clinical domain. We work with pulmonology and critical care. We work with a pulmonologist. The pulmonologist, shockingly, had never heard of OMOP before at each of the sites that we're working on. They really wanted to be part of CureID, but they didn't know how to find their OMOP team. And I can tell you that you are, as a health system in the US, at the least, you're doing a lousy job of communicating your availability within your organization. And I can say that because I'm guilty of it as well. But I feel like we ended up having to find OMOP teams. Basically, we'd scour their websites. That often didn't help. We ended up having to find the OMOP team at health systems by looking at our annual report, seeing that, yes, that organization had somehow submitted that they were an OMOP shop. And then we would try to go through our network of friends within OHDSI. I would say, does anybody know anyone here who was involved in the OMOP transformation of their data? This happened more often than not. And so one thing I think we need to be able to do is understand, how do we communicate to our clinicians internally that we have an OMOP instance? So they don't even know if there's OMOP within your organization or not. How are they going to be able to be our advocates for clinical registries? And so awareness was by far the biggest problem that we had. And this actually usually slowed us down the most by a couple of months to help find where in the organization there was a team that would transfer the data into OMOP. The second issue we found was the OMOP team, and I'll use that term with double quotes because often it was a single individual, was not prepared or had not considered how to provide OMOP data sets as a service. Their OMOP instance had, maybe it might have had minimal clinical domain coverage, had not been really refreshed. It was done by a project. It's not supported, wasn't really validated. It was deemed a research project. And I felt this is where they had the technical talent and they hadn't productionized it. This is where there was a gap between the OMOP team that had done the work and the enterprise organization. And so part of it was helping them build organizational design for how to build that team inside their health system to be able to support more than one project with OMOP. The third challenge that we faced was that the architecture teams often don't have a pathway to bring in software. So a lot of the analysts that we know, they had SQL access, they could get into the data. They were on different database platforms, which we said not a problem. OHDSI supports many of them. And we rarely had a situation where the platform was not one of the ones supported within the OHDSI organization. But what they didn't have is they didn't even often know how to bring software in. And so they understood how to do SQL, but there's often a gap even within organizations between the analytics and IT groups. And so we had to help them navigate the security IT teams and the enterprise IT teams for how to help them deploy software and make that an easier process that we'll be talking about. And lastly, I wanted to mention there's also, of course, a gap we found that there was a gap in mapping source concepts due to disconnects between the analytics team themselves and the clinicians. And so our clinicians try to step in and help, but it's a little bit where we'd like to have a clinician on that side say and verify that, yes, that term is what we think it is, and that's how it's being used and intended to be used. And so we find that there are different gaps in that process. These are the top issues that we found. None of these were technical issues, which I thought was somewhat exciting, is that we're not facing a technical problem. We're just finding an organizational alignment issues where we can help, health systems can really build, save a lot of productivity and efficiency by having an enterprise OMOP team that can support many different registries. Okay, so
Paul, you had a guess of IT security permissions and another guess of data governance. So
that's
could
pretty
you
good.
just comment on whether those came up at all?
Data governance is exactly number 2. I'm going to say data governance is number 2, and IT security would be number 3. In terms of the list of issues that we ran into working with these 36 sites on their OHDSI journey. And so I wanted to bring one of our partners in this to talk a little bit about their journey. Dr. Dwayne Willett is the CMIO at UT Southwestern, and he helped move the organization to implement their OMOP instance and was able to bring it in as enterprise level. So I'm very interested in hearing about how much effort it is today to build out an OMOP instance, and what are some of the ways that you hope to get value out of it. Dwayne?
Great, thank you so much, and appreciate the chance to talk to the group and this topic. Next slide. So we were at UT Southwestern through our CTSA grant award. We actually have a North Texas hub for our CTSA, and seeing the benefits of OMOP and which Paul's laid out. We have proposed transforming our EPIC data to OMOP in all partners of our North Texas CTSA, and you can see them there. Not only our organization, but Texas Health Resources, Children's Health, Parkland, and actually there's a 5th, Scottish Rite, all of whom are turns out are on EPIC. And once we learn more about it, again, all the tremendous capacity on the right side of this slide that goes beyond just ETLing the data was really attractive to us. I would just comment parenthetically that it was hugely helpful to have the Cure ID be invited to participate in this project by Paul and his team early on, because having the end in mind, it really helped focus us and move the project forward. So if you get a chance to do something like that, I think that was tremendously beneficial to moving our project forward. One of the challenges that we saw doing this is, back to that diffusion of innovation. One of the technical barriers for us was getting our EPIC data into the OMOP data model, and that's kind of where our team came in. And because we had to do it at 4 organizations, we began to think about how could we do this in a replicable way. And there's some tools that are available in the community to help do that. We were challenged by my associate CMIO, Mujib Bassett, to ask the question whether we could use the ETL framework within EPIC itself. So their Caboodle data warehouse has an ETL framework, since all the sites already had that. And so we did end up taking that approach as a replicable one, and I'll just kind of show you what that looks like. So we can go to the next slide. So on this next slide, this is EPIC's Caboodle console or Caboodle data dictionary. And what we've done at this point is implement 25 of the OMOP 5.4 CDM tables within Caboodle itself, so that the daily operation that's running the Caboodle extract is actually generating these tables. So there are 10 of them are the vocabulary tables, and then there's 3 health system tables and 12 of the clinical tables. And importantly, because this data is coming into Caboodle, we actually get a few side benefits. One of the things that our researchers brought up early on is they were interested in leveraging the ability of OMOP for network studies and registries, as mentioned, but also for cross-institution research on campus, and potentially including data that was beyond what's included in the OMOP data model. So this allows us to link out to really the remainder of the data in the EHR if needed for a specific project. And so you can see some of that at the top, this entity relationship diagram at A, and including tracking back to the history of the state of the patient or the state of the provider at the time that an event occurred, like were they married at the time, or was a provider a resident versus an attending, that level of detail. Item B there are the standard OMOP fields, and Caboodle does force a naming standard, and I'll get to that in just a minute, which we need to deal with. And then automatically down in this level C is a bunch of metadata columns that, again, the infrastructure just handles automatically, change tracking when the row was created, when it was last modified. So we didn't have to code any of that. That all is taken care of by the software. Next slide. So this is another big benefit is, and this just runs with nightly execution. It's a full history of our EHR. So we've been on Epic for 22 years. So every night this runs. This is an older slide, but I just checked this morning and it finished just before 5 o'clock. So we have the full history up until midnight last night of the data in these tables, and then you can see the kind of the timings on the right. And importantly, they run after the regular tables. So the regular delivery of data to Slicer, Dicer, and Radar dashboards that are used by operations are not affected in terms of timing. Next slide. And so these are, in order to work with the OHDSI tools, essentially the one additional piece is we've created and scripted out a database, a separate OMOP database on the Caboodle server. And again, back to that partnership between IT and analytics, which has been really expedited here at UT Southwestern by having a clinical informatics center that's led by Dr. Lehman and Dr. Bassett. So we were able to get that permission. And then these are essentially views that just rename those tables that Caboodle enforces a certain naming standard on into the names of tables and fields that can be accessed directly by Atlas and the DQD. All these tables have contents. So the numbers you see in blue are just certain ones that have been called out. But for example, there's over 200 million diagnoses, 110 million both drug orders and drug administrations. And our largest table is measurement, where we have all the lab values and vital signs there. And then 85 million full text clinical notes. For example, we have not yet done the NLP to the comment earlier. Next slide. And so this is just an example of a patient that was seen in clinic. And those of you that work in Epic will recognize the visit diagnosis screen. So these were the entries. And then if you hit enter, just as a build slide. So again, by 6 o'clock the next morning, these data are in, again, this full history, 22-year history of diagnoses used at UT Southwestern, mapped to standard concepts and available for use. So from a registry standpoint, again, we see this as potentially beneficial, that really somebody was seen yesterday, was given a diagnosis, administered a medication, or had a CPT procedure the day before, would be present in the data set and available to qualify for the registry as early as the next day. And so that's kind of where we are. This is version 1, but because it was developed through CTSA, obviously it's specific to Epic. It can't be used at Cerner or Allscripts type EHRs, but it is available to anybody on an Epic EHR. And these are what Epic calls data model components, but they're scripted things that we migrate them from development to test production. And by a similar approach, they can just be installed or migrated to another health system site. The recipient health system site doesn't have to code this. And again, in terms of the experience of going through this is mostly a wrapper for transformation code. In many cases, it's already been written. People like Roger Carlson, the group at Colorado, shared their code with us. So again, this is just sort of standing on, building off of great work that others have done that they shared so willingly with us. And again, likewise, we're willing to share this method. Again, we don't think there's one size fits all, and many sites will prefer to have standalone ETL, but for those that may want to leverage their existing Caboodle ETL system, this is shareable to all those sites. So, thanks, Paul.
Wayne, thank you. And I might take you up on that offer myself, because we're a clarity shop and you make a really compelling case with the latency for Caboodle. So thank you so much. And so Dr. Willett took the site from scratch to OMOP. Jeff at Emory, they had an OMOP instance with Cerner, and Jeff had to retool when they implemented Epic. And so I wanted him to talk about what the journey is like when they are having to they have to retool in that process. Jeff?
Thanks, Paul. Appreciate it. Do you want me to share some slides, or do you have that on there?
I can just advance for you.
Oh, okay. You have them. Great. So I'm in the interest of time here, I may skip through some of these a little faster, but just wanted to give you a little bit of context around Emory. We did have OMOP here at Emory, but it was not at enterprise level. So we had projects that were working with different groups. There was not consistency among those groups. That wasn't the same teams, and they had their own mappings. So we were really kind of disparate in that way. And then we also, and this is kind of the spoiler alert, we had a lot of registries that were coming up that needed the OMOP data. So that was a really big driver for us in moving to an enterprise version. And we had some things around I2B2 we did use, but it wasn't being used that much. And then kind of the big thing that happened with us is that, as Paul said, we moved from Cerner to Epic. And this happened just recently, last October. So it's not even been a full year that we've been at Epic. So we really wanted to think about how can we make sure those two sets of data fit together, and that we can work with this large longitudinal data instead of just two different sources of data. So next slide. So this is a slide, and many of you, if you're on this call, you already know these things, but this was just to show what we presented to our leadership. We really need to be those champions to show the value. We know the value of what OMOP can bring, but we really need to make sure we're showing the value to our leaders and those that are holding the money for us to do these things. I wanted to point out to the last one here is something that I think really got excitement with a lot of people, was not only did we want to make sure we integrated our Cerner data with our Epic data, but we also had a lot of partners. We have a lot of our Emory faculty that work in Children's Healthcare of Atlanta. They work in our safety net hospital, Grady. If we value population health, if we value transition of care, if we value things like long-term outcomes, being able to put all that data together regionally is really a lot of value. And so this is something we've been talking to Children's with, we've been talking to Grady with, and we're really hoping to find some real momentum there. Next slide, please. So how did we eat this element, or how do we eat this elephant? It was CureID. So I think this is what really was the catalyst to help us go from having all these separate instances to really having an enterprise version of OMOP. And we are still working on the Epic version of this. We really tackled the Cerner version first, particularly because in the case of CureID, all our data that was related to our COVID population really was in our Cerner data. So next slide, Paul. So this is how we approach this, and this may seem obvious in retrospect, but really this was really a kind of a game changer for us, is that having a project like CureID to focus on was really big. Not only did that give us our the resources from John Hopkins' perspective and the folks that helped us, but it also helped have an analyst that specifically focused on CureID and helped us curate this data. And one other additional thing that I don't have in this slide, so we identified that project, but we also made sure we implemented the tools. So we have Atlas, data quality dashboard, and Achilles. Those things were really important for us in getting past level 1 to level 2 and really curating the data. And by the way, I think we have 98 or 99% on the data quality dashboard, just to brag a little. The other things that I thought were really important to this is we only brought in the data that was relevant from a time perspective. And this helped us really curate that data quickly. It helped us refresh our ETL. It helped us iterate on when we found changes that we need to make, we could make those quickly. So we, of course, plan to expand that data, but we really limited to really about a 3-year period so that we could get this data nice and clean and ready for use. And it also allows us to find some really immediate value when we take a project like CureID and focus on that and get that data out. And then lastly, we focused on the depth instead of breadth. And in other words, we really made sure that those variables that are interest to CureID, and it goes back actually to a slide that Paul showed earlier, focusing things on like respiratory support, making sure that not only do you have those concepts, but also all the possible results of those concepts being mapped. So, whether it be for a mask or even outside air or a combination of all those, just making sure those things are specifically mapped so that you provide value to the project that you're working with. Next slide. Just wanted to show our project team here that this is what we used to implement. We had a technical lead, we had someone doing the ETL, we had that analyst, as I said, focused really on CureID specifically. We had our clinical SMEs both on the inside of Emory and also using Johns Hopkins folks. And we also had someone on that knew OMOP really well that we brought in to help us do those mapping to the terminologies and also mapping to the model. And the last slide that I'll share is just really briefly this infrastructure of how we implemented here at Emory. I'll point out just a few things. One, that in our case, we use Redshift, and I can, on another time, I can talk about why we went that route. We also used what Lee will talk about, the Broadsea Docker container to set up our instance, and we also made it all within the cloud. So everything is within AWS. We're using a data lake from healthcare that pulls data in. So that's been a really easy pipeline to build. And we also made sure that we have this single sign-on built in this to really make sure this passed through our security process. So I forget if I have another slide or not, but I think that's really what I wanted to say. I think you should all, probably realize what this value of these groups are. We're already really seeing value of doing OMOP at an enterprise level. We're getting more and more people on board, not just from a registry's perspective, but even internally, those that are trying to build out, like for Goizueta is a large brain health initiative, and they're bringing in our data, our OMOP data into their instance to help build out their initiative.
Excellent.
So that's it.
Jeff, thank you so much. And so I said one of the other things we were really excited about the CureID is that we were able to invest in Broadsea to get the package of tools into a health system, into a more supportable, deployable framework. And Lee, if you don't mind, I can give you about 60 seconds if you want to quickly go through what you accomplished over the last 2 years.
Yeah, I think if we just start on this slide and the last slide. So
Okay.
what I wanted to show here is that with CureID, we're able to align Broadsea to some of the CureID goals. So we have ETL supported in 2 ways with Perseus and DBT. And incidentally, we're also extending out to sharing evidence as well. So Broadsea is just the fastest way to get Atlas installed, I would say. So we skip to the last slide that I had. I think that would be useful. So I did work with Jeff's team to install Atlas. It was great working with them. It's a great team. And I just wanted to talk about the benefits of using Broadsea. So Broadsea lets you have kind of an instant demo of Atlas, so you can share that with the rest of your community at the site. You can use that demo to verify the infrastructure and configuration. That's sometimes quite difficult to know, is it my version of Atlas or is it something about the servers? We used RStudio to be able to run Achilles, so that was really great. And so a quick installation, security enabled. There's a lot of authentication methods with Atlas. We were able to use certificates. We were able to set up single sign-on with our enterprise solution. Really great to be able to log straight into Atlas with no hassle of passwords and things. And then lastly, we have the ability to do simple upgrades. So whenever there's a new release of Atlas, you can download the new release of the Docker container.
Yeah, I think this work has been incredible. I think Broadsea should be used by everybody as your first option. Is there should be a reason why you shouldn't use it, because it should make your life so much faster in getting all of your OHDSI software onto site. So Lee, thank you so much. We're almost out of time. I wanted to mention one last thing. As of last Thursday, I'm happy to announce we have our next generation clinical registry coming. We've been awarded the Data Core grant for the NIH Maternal Health Research Centers of Excellence, which will be a very exciting initiative to help study pregnancy-related complications and deaths and promote maternal health. And as part of this grant, we are also going to be focusing on, we've really tried to figure out how ways we can expand the OHDSI community we've partnered with the OHDSI Coordinating Center. So we'll be using Teams and GitHub repos. We're going to be continue to enhance health ETL systems and train scientists in OHDSI methods. In our aims, we have implementing OHDSI analytic tools in organizations and funding open source development, as well as supporting even educational initiatives to help train our researchers. And we intend to do execution of our network studies within the OHDSI data network. So I think it's really exciting to see how we're evolving as clinical registries start partnering more and more with OHDSI, and how we really have such great synergy with this new community that's going to be joining ours. So thank you so much for your time, and I'm going to hand it back to you, Craig.